Hey everyone, if you're in medicine, you are absolutely going to see patients with fibromyalgia. So today, we're going to dive into a clinical primer that's really designed to get you up to speed on the modern way to diagnose and manage it. Let's jump in.
So, first off, why is this so important? Well, fibromyalgia is not some rare, obscure diagnosis. It affects about 2 to 3% of the population. I mean, that's a huge number. It means that in any general practice, you are guaranteed to see and manage patients with this condition. It's really bread and butter stuff in modern medicine.
Okay, so a patient comes to you with pain all over. And, the first thought for a lot of us is inflammation. Maybe something like rheumatoid arthritis, right? But is that what's really going on here? This question, it's central to understanding everything that comes next, from how we diagnose it to how we treat it.
So here's our game plan for this explainer. We're going to start with the core clinical features. Then we'll bust a major myth about what causes it. After that, we'll walk through the modern diagnostic tools, build a really holistic treatment plan, and finally talk about how to frame those long-term management goals.
All right, let's start with the absolute basics. What does fibromyalgia actually look like when a patient walks into your clinic?
The number one thing to get is that fibromyalgia is so much more than just pain. It's a whole constellation of symptoms. Yeah, you have that hallmark, widespread chronic pain, but it's almost always coupled with this profound fatigue and non-restorative sleep. Your patients will literally tell you, "Doc, I wake up feeling like I haven't slept a wink." Then you add in the cognitive stuff, that fibrofog, plus other issues like headaches and IBS, and you start to see this picture of just total polysymptomatic distress. And remember, you're going to see it a lot more in women, usually starting sometime in middle age.
Okay, so this brings us right back to that initial question we had about inflammation. And I'm telling you, this is probably the single most important conceptual shift you have to make to understand this condition. Let's be absolutely crystal clear on this. Fibromyalgia is not an inflammatory or autoimmune disease. The pain your patient feels is 100% real, but, and this is a huge but, it is not caused by tissue injury or inflammation in their muscles and joints. This is so crucial for both you and your patient to grasp.
So if it's not inflammation, what in the world is it? Well, the leading theory is something called central sensitization. Honestly, the easiest way to think about it is that the volume knob for pain in the central nervous system is just turned way up. The brain and spinal cord are amplifying pain signals, so stuff that shouldn't be painful at all is perceived as pain, and things that are only a little bit painful, they become intensely painful.
And look, this isn't just some vague idea. There's real, growing evidence to back it up. Neuroimaging studies actually show differences in the parts of the brain that process pain in these patients. And we're also seeing more and more data that points to a genetic predisposition, which helps explain why it seems to run in families.
Okay, so with this whole new understanding of what's going on in the nervous system, how does that change the way we actually diagnose the condition?
Well, the change has been pretty dramatic. A lot of you have probably heard about the old tender point exam, where you'd press on 18 specific points on the body. We don't do that anymore. The modern approach is based entirely on the patient's reported symptoms, which is a much more reliable and, frankly, patient-centered way of doing things.
So why did we ditch the tender point exam?
Well, it had some major flaws. For one, the results just weren't reproducible. You could get different answers from different doctors, and it was especially bad at picking up fibromyalgia in men. And here's the really interesting part. The number of tender points a person had actually correlated more with their anxiety level than with their pain. Plus, to do it right, you technically needed this special pressure gauge that almost nobody has in their clinic.
So this is the new standard. The criteria, which come from groups like the American College of Rheumatology, really just rely on two main things. First is the widespread pain index. It's basically a checklist of painful areas on the body. Second is the symptom severity scale, which scores things like fatigue, sleep problems, and brain fog. And the absolute key to the diagnosis is that these symptoms have to have been going on for at least 3 months.
Now listen up, because this is a really high-yield slide for your actual practice. Please avoid these common pitfalls. Do not just shotgun an ANA test unless you have a very specific reason to suspect a connective tissue disease. A low positive ANA is super common in the general population, and it can lead you down a dangerous path of misdiagnosis and unnecessary, harmful treatments. And if your patient does have something like lupus, you have to remember that fibromyalgia can coexist, and it might be the real reason for their pain. Overtreating them with more immunosuppressants won't help and could hurt.
All right, so we have a diagnosis. How do we even begin to approach treatment? The key word here is holistic. This is not just about writing a prescription.
The best management plans are really built on these 4 pillars. And I want you to notice something. Medication is only one of the 4, and it's last. The real foundation of effective care is in the non-drug strategies.
Let's break these down because they're so important. Education is number 1, hands down. You have to validate your patient's symptoms. They are real. Then reassure them that this pain, as awful as it is not causing permanent damage to their body. Next is exercise. This is tough because it can make things worse at first. You have to start low, go slow, and be their biggest cheerleader. And finally, psychosocial support is critical. You got to ask about stressors and consider referrals for things like cognitive behavioral therapy, which can be a huge help.
Now, when we do turn to medications, we're targeting specific symptoms. We've got things like gabapentinoids for the pain signaling. We've got older tricyclic antidepressants like amitriptyline, which can be fantastic in a tiny dose at night for sleep. And we have SNRIs like duloxetine, which can help with both the pain and any comorbid depression. And please note what's at the bottom. The evidence just doesn't support using things like ibuprofen for fibromyalgia pain. It's not an inflammatory problem, remember.
Finally, let's just zoom out for a second and talk about the big picture. This is a chronic illness, and setting the right expectations from the get-go is absolutely key to a successful therapeutic relationship.
I really want to let this quote sink in for a moment because it's so important. This is from the source material, and it is a major reality check. We are not curing fibromyalgia. Success is going to look like partial benefit, and you'll probably have to cycle through different treatments over time as some stop working. So what this means is that we have to totally reframe the goal. It is not about getting their pain score to 0. The goal is to partner with your patient to help them manage and cope with their symptoms so they can maintain their function in daily life and preserve their sense of autonomy. That is what a win looks like.
And that brings us to the end. I really want to leave you with this question to think about as you move forward in your training. This isn't just about prescribing the right pill. It is about building a long-term partnership. So think about what that alliance really looks like and how you will empower your patients to live their best possible lives, even with a chronic condition. Thanks so much for joining us.